What the Cotton Method is, it's a complete oral cancer office system to bring confidence in screening, build the team, and reduce liability. And actually, by doing all of those things, we increase early detection and save lives, which is ultimately what we want to do, right?
In addition to us doing oral cancer exams and looking for the lumps and the bumps and the changes in the tissue, I think one of the things we really have to focus on is helping people to look in their own mouths and to try to teach them what to look for.
You may go in with your idea of how to do a thorough examination, but you may be with a seasoned hygienist who's been in the field a long time who's not used to doing that. So not only may you learn something from the seasoned professionals, but they may learn a lot from you too. So it's a great opportunity to change the things.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 274.
Good job.
Thank you. My name is Andrew.
This is Michelle. And I'm kind of back, y'all.
I am just so happy. You're not kind of back. You're back. She's back, everyone.
I'm back. And if you don't know what that means, I took a little hiatus. Even though I've been on the intros and stuff, I wasn't conducting a lot of most of the interviews, like 93% of the interviews was all Andrew.
Essentially, it just reversed from whatever happened last year and part of the year before. So I am officially back. It was a lovely little break. I got to really focus on my new job over at Mouthwash and getting Level Up off the ground. And now I can kind of come back and learn. And this was a great one to join you on. Yeah.
This is our roundtable, our first of the month.
Yeah. It's interesting though. This one did have a different vibe. I could tell how much smarter our audience is going to be now that you're back on the show. Just want to say that. You asked so many great questions. Like your train of thought is so different than mine. And what
makes us a great duo.
No, I know. But I think it also is what made me a little bit frustrated at times. Because I'm like, just ask the way I wanted them to be asked or whatever. So you guys didn't know what a control freak I really am behind the mic.
Well, yeah. And just as a behind the scenes, where this started with this little podcast, you mostly heard me, but Andrew was producing it and sending me these questions. Ask this one next. Ask this one next. And I was like, enough. You asked the dang question.
Because people don't want to hear from me. I think everyone loves.
Yes, they do.
Oh, okay. Anyways, look, this is a dental podcast, by the way. Just if you're a first time listener, this is very typical Michelle and Andrew arguing with each other right away.
Banter.
And then, banter, I guess. But we'll get into some dentistry here in a little bit. This week is our student roundtable, and it's on oral cancer screening and detection.
Mm-hmm.
I had more to say about that.
And it was pretty great. We've talked about this before. We keep this podcast going selfishly in some ways because we have front row seats. We can ask all the questions to some of the smartest people in our industry. And I have very much missed learning every single week or however often that we do episodes. And I very much learned a ton on this. And I'm one that has always done oral cancer screening. I was very lucky to have that instilled, we learned it in school, but the perio practice we biopsied stuff. And so from the moment I entered into the industry as an RDH, all of my doctors were very big on doing oral cancer screening. And this was great because I have that already kind of in my rhythm and my flow. But man, I'm changing up my verbiage. I'm changing it up. I'm going to ask different questions. I'm going to say different things. And that's exciting for me.
Did you know by the chance that all of them knew each other?
No, but it makes sense because that oral cancer world is kind of small.
I think it speaks to the thing that I know we talk about this a lot, but it's the whole networking and it's whole, being a part of the hygiene community. So as a background for the listeners, so Michelle reached out to a few guests. I reached out to one of the guests and just completely independent of each other. And this is who we want. This is who we want. And then we brought them all on. And when they're doing their introductions, they're like, oh yeah, and by the way, we all work together doing this thing. I'm like, oh my gosh, how fortuitous is that? That's so amazing.
And you're right that it's about networking and also finding that like specialty, that little niche that you love so much in the industry, and just diving into it and networking like crazy within even, I know we're in a niche market anyway, like dentistry and then dental hygiene. And then, you got your East Coast, West Coast, whatever, but perio and oral cancer and airway and myofunctional and cardiology. I mean, there's so many little niches that you can go and specialize in and network like crazy.
For sure. Oh, I think that, there's another thing to that, though, is there's a way to network, and there's a way to, like, they could easily have said, no, this is my territory. You guys can't come in. We can't, do the whole propel the profession forward. And they chose to go the other route, which is, collaboration and helping for the greater good. I love that.
Yeah. And if, this is a student roundtable, we really try to speak to the students on this particular episode each month. And I hope that's all you find when you leave school. I hope.
Yeah.
It's not going to be. I hope you never have to experience people trying to shut you out because that's their space or that's their territory in a way. But know that there's two ways of handling that. And if you are encountering that, there are other people who will welcome you with open arms.
For sure. And so with that, I hope you guys enjoy this week's episode. Hey everyone, before we get into the roundtable, I need to give a quick plug for Q Optics. I cannot believe it has been more than a year since Chicago Midwinter of 2020. I remember clearly the day at the conference when we stopped by the Q Optics booth to get measured for loops, and beyond the high quality of their products, I was impressed by their professionalism. If you are a student listening to this podcast or a faculty member looking to help out your students, reach out to our friends over at Q Optics and get them into your program. You have heard on our show many times, we fully support using loops during clinical care and highly recommend investing in a light as well. You'll be happy with that choice. To find out more and see what else they have in store, check out qoptics.com. That's q-optics.com. And now back to the show.
Well, welcome to the interview portion of this roundtable. I just love the roundtables. Anytime I get to just take in all the smart people that I can have the opportunity to meet. And this one is going to be on oral cancer because April is Oral Cancer Awareness Month. So we're really excited to have 3 powerhouses who are really doing amazing things, helping us become more educated, but also they sit on boards and all kinds of stuff in the world of oral cancer. So I want to welcome Susan, Maria, and Jill. And I would love, Susan, you can take it and tell us a little bit about who you are and what you're doing.
Okay, well, thank you. It's really an honor to be here with you guys today. So I'm Susan Cotton. I'm a dental hygienist in Colorado, and I am owner of Oral Cancer Consulting. I consider myself an oral cancer coach, and I developed the Cotton Method. And what the Cotton Method is, it's a complete oral cancer office system to bring confidence in screening, build the team, and reduce liability. And actually, by doing all of those things, we increase early detection and save lives, which is ultimately what we want to do, right? And recently here in Colorado, I took a contract position with the state of Colorado as their dental lead for HPV Free Alliance in Colorado. And it's just doing more of what I do, educating, speaking to dental offices and schools. What I love to do most is go into a dental office and help them become confident in their screening and look at all of their systems to make sure they're up to date and doing all that they can to bring excellence into oral cancer. I do have a course the whole month of April with Beyond Oral Health every Wednesday evening. We are taking a deep dive into oral cancer.
That's awesome. And Maria?
Hi, everybody. And thank you, Michelle and Andrew, for inviting me to participate. My name is Maria Perdo Goldie, and I am a past president of the American Dental Hygienists Association, as well as the International Federation of Dental Hygienists. I have done clinical practice, education, research, many things in my long career. regarding oral cancer, my first real entree into that was when I was doing research at University of California, San Francisco, with the late Dr. Margaret Walsh, where we did spit tobacco research, of course, having to do with oral cancer. And then for 10 years or so, I was a member of the Smoking Cessation Leadership Center, which dealt not just with smoking, but all kinds of tobacco, its relationship to many different maladies, including oral cancer. And currently I am on the Dental Hygienist Advisory Board of the Oral Cancer Foundation. So I feel very fortunate and honored to be asked to be a member there. So in my CE courses, as well as in my private practice and other areas of my world, I do stress the causes and prevention of oral cancer, such as we know the old things, smoking and tobacco use and alcohol use. And now, of course, we know HPV is a huge factor. So that's a little bit about me, and I look forward to participating in the podcast.
Thank you. And Jill, welcome.
Thank you. Yes, as they mentioned, I'm very happy to be joining you today and honored that you asked for me to be part of this group. My name is Jill Meyer-Lippert, and I'm a dental hygienist in Wisconsin, and I'm the founder of Side Effect Support LLC, and that is an online resource for cancer patients, family caregivers, and healthcare providers to help reduce harmful oral side effects of treatments. So while I do obviously really promote the early detection and try to do a lot of education with that, I also focus a lot on the survivorship aspect and what people are dealing with many, many years after their treatments may be complete. And I'm also on the Dental Hygiene Advisory Board for the Oral Cancer Foundation, along with Maria and Susan. And I am also the Community Relations Manager for Custom Dental Solutions. So wear quite a few hats and love all of them.
That's awesome. Andrew, do you want to take the first question?
Yeah, I think this is going to be a softball question. I think it's just kind of get us in the mode. I would love each of your opinion on, do you think that we're placing the appropriate weight on screening and detection in our field? Susan's already shaking her head no. She's like, no. So go ahead, Susan, take it away.
Well, I don't feel that. And really I think the overall issue is, as dental hygienists, we have so much to do in our given amount of time in our hygiene appointment. But I don't feel dentistry as a whole has placed the emphasis on oral cancer, HPV, and the importance of screening every patient every time. I've been there. And that's really how I got started, was my clinical shortcomings, because I let the busyness of my day, a late patient, get in the way of completing that thorough oral cancer screening. That's what put me on this path. So I think dentistry, we can do so much better.
Maria?
Well, I agree. I think that when we look at the numbers of people that have oral cancer, the numbers have not changed in many, many years. So we're not doing something right. But I do have a little bit of hope and faith, because I do feel that dental hygienists are now a little bit more aware. For instance, with the Oral Cancer Foundation today, beginning April 1st, there is something that you can put on your Facebook page. You can put the photo that says, "Help Us End Oral Cancer," and has the oral cancer website, so that it brings awareness, a little bit more awareness than what we had before. And I know just in my office in San Francisco, I'm not there as much as I used to be, but there are a number of hygienists there, and I'm noticing more in the notes, oral cancer exam. So even though we could do much, much better, I do have some hope that it's gotten a little bit better.
Yes, and I agree with that also. I started becoming involved with the Oral Cancer Foundation in 2014. And I believe at that time they estimated about 36,000 Americans would have a new case diagnosed that year. And this year they're anticipating 54,000. So because of the HPV virus and, some different shifts in causes, that is really changing some of these numbers. And unfortunately, even though if they're caught in really early stages, you can have about an 80% survival rate if they're caught at that stage 1 or 2. there's only about, I think, less than 30% are being caught in those early stages. And, whenever I do my educational programs, I always stress that that is on us. We really need to take some responsibility to go that extra step for people and look and not expect that it's going to be obvious just with our general clinical examination.
Do you feel that there are more factors now that we need to be looking at that are increasing risks than ever before? Or do you think that it's kind of always kind of been the same?
I strongly believe we have more risk factors. HPV is a game changer. And my company is called Seminars for Women's Health and Sex-Based Medicine. So I've always focused on the differences between men and women. And cervical cancer is something that HPV has been involved in for years. But now we know it is the leading cause now of oral cancer. And the difference also is that it's not older people, older men as an example, that used to be smokers, drinkers, and they find out in their 5th or 6th or 7th decade that they have oral cancer. Now we're looking at young people, especially young men in their 20s that are getting HPV because it is a sexually transmitted disease. And I do believe that there are a lot of dental hygienists and dentists that feel very uncomfortable discussing HPV with their patients because it is a sexually transmitted disease.
So as far as additional risk factors, so we've known historically tobacco use in all forms, alcohol, and now HPV, but there are other risk factors, genetics, a family history, periodontal disease, we know is a risk factor. The mouth is not healthy. There are a couple of genetic factors that put someone more at risk. Dyskeratosis congenita is one. Graft versus host disease puts someone at a higher risk for oral cancer. So there are additional things. Are those less than HPV, tobacco, and alcohol? They are, but they are risk factors that we need to be aware of and have those questions on our health history forms so we can do a really thorough risk assessment of our patients.
And I agree that is something that I think we battle within the industry, but also as for our patients, is that stereotype of what through all of these years we've pictured this stereotypical oral cancer person to be, the older, heavier smoking, drinking male. And that's just not the case anymore. So we do have some public education to go. And I think that's one really neat thing with the Oral Cancer Foundation too, is that they've made some steps to help patients help themselves by creating a website called checkyourmouth.org. And it actually leads patients through how to do their own oral cancer screening. So people can see some of these signs and symptoms that they maybe would otherwise dismiss, but now they can say, oh, I'm noticing this, and that gives us a better option to find things at the earliest stages as well.
What are some of those things, just out of curiosity, Jill, that they're looking for in their mouth?
You want to look for any lumps, bumps, ulcerations, or color changes. And there's other aspects as far as when you go into certain types of cancers that have progressed, there might be pain in one ear, hoarseness of their voice. As a general rule for any type of an ulceration, there's kind of a 2-week rule that, our mouths are so prone to trauma, whether it be toothbrush trauma or we get scraped with a pizza crust or, hot soup or something like that. So we've got trauma in our mouth all the time. But typically, because those cell layers have a pretty rapid turnover rate, it heals pretty quickly too. So if somebody does have something in their mouth that's unusual that lasts over 2 weeks, that is usually a sign that they do need to have that looked at.
Maria?
I'm glad you mentioned checkyourmouth.org, Jill, because this is a very user-friendly website for individuals to go to that are not professionals. And they can look at the tools that are there and learn how to check their own mouth. There's a new product called the Throat Scope, which is, they partnered with the Oral Cancer Foundation. And it is a visualizing tool with a light, and it's very, very user-friendly. So in addition to us doing oral cancer exams and looking for the lumps and the bumps and the changes in the tissue, I think one of the things we really have to focus on is helping people to look in their own mouths and to try to teach them what to look for. So checkyourmouth.org and Throat Scope, very, very good tools for people to use.
Susan, you raised your hand earlier. I wasn't sure if I missed the point?
No, I just wanted to add to risk factors. There's research out that's showing oral cancers with no known etiology have risen a little bit. Those used to be around about 3 to 5%, and that's increased to about 7 to 10%. And they're seeing that in young women, young being under 40. I was kind of offended by that. No. But that is so, even if someone appears to have no risk factors, we just have to look at it as everybody potentially is at risk and treat everybody the same, screen them thoroughly.
Jill brought up the point, we're changing the face of who is, and that it feels very similar to changing the face of our sleep apnea patients. And I've always felt like even when I was doing my sleep apnea screening or just airway screening and my oral cancers, there's so many parallels to it. And man, I don't know, it sits with me. I'm like, we could make some big changes if we do these things.
Maria, were you raising your hand?
Yes, I was just going to mention that today, just across my desk, I saw that the Canadian Dental Hygienists Association Journal just published an article, an actual issue on oral cancer detection. And of course, we know that early detection and intervention is vital to get our numbers down as far as mortality and morbidity. So I just wanted to bring that up. If you just go to the Canadian Dental Hygienists Association website and go into their journal, it's a great issue. They have a lot of good peer-reviewed articles in their journal.
We'll put a link for that in the show notes.
Yeah, thank you.
Okay, keeping in mind that these roundtables are primarily for the students, I would love if we could just quickly talk about day one, you're going to be going into a practice that you're probably maybe not familiar with. How can you start the process of screening and detection? What are the tools that are out there? What might you find in an office? What protocols might you find? What might you need to implement in the office that's not already there? Go ahead, Maria.
I think because oral cancer detection and education is now a little bit uncomfortable for some people, especially for a new practicing dental hygienist, because you're not used to discussing really personal issues with your patients. So I think that having a protocol in place, protocols are wonderful. Have a sheet of paper or something on your computer screen where you have questions that you ask and get answered. And so it's not so personal. I mean, yes, they're personal questions, but it's more like I'm not just asking this to you. I ask it of everybody. These are professional questions that I ask, and yes, some of them might be personal. So I think if you're following a protocol, it doesn't feel quite so invasive for someone's personal space, if you will. So protocols help, and making sure you have some type of a script is often extremely helpful.
Susan.
As a new hygienist going into the real world, one of the best things that you can do is utilize that time that you are doing that thorough head and neck oropharyngeal cancer evaluation to educate your patients and talk to them about it. One term I like to use, talking about HPV, for some people, it's uncomfortable, some people not. But I like to use the term what we know now. And while you're screening, say, what we know now is it's not just tobacco and alcohol. There's a sexually transmitted infection, very common, that almost everybody will be exposed to at some time in their life. And that's a common cause of, I like to say to my patients, throat cancer instead of oropharyngeal, so throat cancer. And just saying that, what we know now is this, it opens up the door to the patient. What I found is they'll either respond or they won't respond. And then that kind of guides you on where to go with that patient in that conversation. Some people will say nothing, and some patients will say, oh, I heard about that, and they'll want to know more. So use that as a guide with your patients and just what we know now. And we can use that in dentistry in so many areas because we know so much more.
Yeah, and I think there's a great advantage for making a change within a practice when you are new to it, and whether you're a new student just entering into it or you're a seasoned hygienist that's starting in a new practice, to take that as an opportunity to let your team know, I would like to do thorough oral cancer screenings for all of our patients, and can we make sure we're all on the same page? Have a staff meeting where the hygienist and the doctor are all doing it together and make sure that everybody is doing it consistently. Because I think that is one thing. You may go in with your idea of how to do a thorough examination, but you may be with a seasoned hygienist who's been in the field a long time, who's not used to doing that. So not only may you learn something from the seasoned professionals, but they may learn a lot from you too. So it's a great opportunity to change the things.
One of the things I find very, very helpful are using visuals. And one of the oral cancer visuals that I find very, very helpful is published by the FDI, the World Dental Organization. So it's fdiworlddental.org, O-R-G. And they have a really colorful oral cancer guide that can be downloaded at no cost. And it talks about the risk factors. So if you just show this to your patients and talk them through the main risk factors, the other risk factors, and then it talks about before, during, and after treatment. And then it actually goes through what an oral cancer exam entails. It can be printed out and laminated. And also, if you go to the FDI, they have a lot of other resources there that are available to help you as a new dental hygienist to become more comfortable with doing the things that you may not be quite so used to.
So if HPV is kind of the big one, right, that we know it's not just alcohol, it's not smoking. What about the vaccine? And I'm not talking COVID vaccine, because I know that's headlines everywhere, but there's a vaccine for HPV, correct?
Absolutely.
Mm-hmm. Yep.
Who wants to touch on that? Can you tell us a little bit about what's happening with that? And yes, Susan.
In Colorado, that's something that with HPV Free Alliance that we absolutely talk about. And the vaccine it's very safe. It's been around for a long time. It's recommended for both males and females. It was first recommended for females. And talking about the Oral Cancer Foundation, Brian Hill, the founder of the Oral Cancer Foundation, was instrumental in helping to get that vaccine approved for boys because they are at such a high risk for oropharyngeal cancer. But it's a safe vaccine. When administered between ages 11 and 12, that's when there's the best immune response to the vaccine, is that age group. So they recommend it 9 to 14, 2 doses. If the series is started at age 15 and over, it's a 3-dose series. They have approved it through age 45. It used to be to age 26, but now it's up to age 45. And there's some new research out of Sweden that is showing very promising results in reducing precancers, cervical precancers, and cervical cancers. And they're doing some research on oropharyngeal cancer too. It's a cancer vaccine, and that's, I feel, the way we need to talk about it as a cancer vaccine, because it's not just oropharyngeal, it's penile cancer, anal cancer, cervical cancer, vulvar cancer.
Yeah, I agree with that with Susan, how to frame that for your patients really makes a difference, because when we're talking with our parents, the patient's parents, they don't want to look at their child at 12 or 13 and associate that with a sexually transmitted disease. And that is it's very difficult for them to picture that. They want to put maybe some blinders up and become more resistant to it. But if they know that is a lifelong protection from different types of cancers for them, it can make a big difference in how they see that.
And to Jill's point, the parents don't want to, my child might be or will be someday, because I've come up against that. And what we know in this world is not everybody gets to choose when their first sexual encounter is. And there is sex trafficking, there's rape, there's so many things. So it's not based on, oh, my child will wait. It's life. Those things can happen. And what if someone they're with has an experience that they didn't choose, or their child does, and they're exposed to this very, very common infection? That vaccine early will help protect them from these cancers.
Great points. Maria?
I think it's important that we, as healthcare professionals, talk about vaccines in general, because they are prevention. They're prevention against all kinds of diseases. And now in our COVID world, we should be encouraging people, if they're not getting it, to get their COVID vaccines. But back to the HPV vaccine, it's vital. It is vital to start, if possible, before the first sexual encounter. And it helps, as Susan was saying, not just with oropharyngeal cancer, but for cervical cancer and other cancers as well. It is a prevention strategy. And I know I've heard people, parents, saying, well, I don't want my children to be getting this because then they'll think they can just go ahead and have sex. And there's research to prove that's not true. That is not what happens. So again, talking about the positive aspects of prevention and how vaccines are one of our tools for prevention.
That's a great point. I'm curious so let's say maybe we have some new grads that are listening, maybe even some veteran professionals that have not included the oral cancer screening in the rhythm of their appointment. And I always talk about the rhythm of the appointment because I'm always such a, this is where I start and this is my flow. And at least when somebody interrupts me, I know that's where I got interrupted and I keep going, right? Is there something in the rhythm of your conversation that could be easily duplicated by a newbie, a novice at this conversation? Are you conducting the oral cancer screening while talking to them? Are you talking to them first about this? Is it a little combination of a little bit at the health history and then once you kind of start doing the palpation? What does that look like for each one of you? Maria?
What I like to do is when I'm having my patient sit down, I review the health history or take a health history depending on if it's a new patient, but often it is a patient of record. And I will review the health history. I will say, before I start my treatment, I would like to actually, while you're sitting up, I'd like to perform an oral cancer exam. And I talk to them about while I'm doing it, I talk to them about why I'm doing it. And often they will say to me, nobody's ever done that before. And if they're new, obviously they won't be saying it if they're not new. But I explain to them, well, I don't want to ever get anybody in trouble or throw anyone under the bus, so to speak. So I just said, well, things have changed and perhaps your other hygienists or dentists have done this, but they just haven't discussed it with you. So I'm discussing it with you. I'm letting you know the steps as I go. But this is what we should be expecting at our examinations.
I've done the same thing, Maria, with verbiage as far as when I would perform an exam and they would ask, well, why hasn't anybody done this with me before? Being just cautious of how you handle that, especially if you are a new hygienist coming into an office. And as Susan said, now we know this is on the rise and this is what I'm looking for. And that is, I really like to say not only why I'm doing it, but what I'm doing as I'm looking, as I'm palpating, I'm looking for any lumps, bumps, sores, discolorations, and that plants in their mind too of things that they can look for at home. Because sometimes once I tell them what they're looking for, I can see that light bulb going on and be like, oh, yes. Well, now that you mentioned that, could you check this area for me? Where it's something that really didn't sink into them before, that maybe that's something that needed to be examined. So
it's great. I never thought, I haven't done that. My vernacular for the conversation. Yes, Susan.
Well, I just have to ditto what both Maria and Jill said. Another thing that when I go into a dental office to help coach them with their oral cancer office system is an oral cancer risk assessment, a separate oral cancer risk assessment. We have a risk assessment for caries. Why don't we have an separate oral cancer risk assessment. And so I've developed one for offices to adopt if they choose to, because what that does, they're filling that out, and that in and of itself starts that conversation and asking those pertinent questions of difficulty swallowing, persistent pain, any, persistent cough, all of those questions. And as they're reading that, like Jill said, the light bulb goes off. Oh, well, gosh, maybe so. And it just starts the conversation. When I went in for my mammogram last, they gave me an iPad, and there were probably 24 questions that they had me answer on the iPad before my mammogram. It was a risk assessment. And I was thinking, oh my gosh, I didn't know about that, or I didn't know about that one. And it made me start thinking about my family history or other things that maybe I was at risk for breast cancer and didn't realize it. So starting that conversation with that written risk assessment, I think, helps.
Actually, I just wanted to mention about one thing with screenings, that if you are starting at a practice that has one of the fluorescent devices, I'm a big fan. I use fluorescence for many, many years. And I have found that a lot of offices that have it do not use it correctly. And what they do is they will do a white light exam. And it's only if they see something that they think is concerning, they pull the light out and shine on it. It's not a diagnostic tool. So if that is how a practice is using it, that is not being used correctly. It is meant to be a screening tool to be used on every patient to find areas, changes in the tissue before you can see them under the white light. So basically, under fluorescence, healthy tissue will glow back kind of a whitish green color. But if there's changes in the fibrin and the collagen in the tissue, it loses the ability to fluoresce. So it actually looks like a dark spot. So that being said, you're going to pick up a pizza burn or a cheek bite. But that is where that 2-week rule really comes into play again, where you can document what you're seeing, have them come back in 2 weeks and check it again under the light. And if it's still there, then it's assigned to investigate further. But honestly, the vast majority of things you see will be fine in 2 weeks. But that way you can, again, find things at the earliest stages, which is really the main goal.
I think that as a new dental hygienist, one of the things you can do to feel comfortable with your exams is to really educate yourself. And one of the best places to go is the Oral Cancer Foundation website, because it talks in depth about things like screening and understanding the process of oral cancer. It has a specific area just for dental. It talks about all of the research, and it has also a lot of different resources. So I think once, I know as a speaker, if I have layers of information, I feel much more comfortable being able to deliver a presentation, knowing that I can answer most questions. And if I can, I just say, I'll get that answer for you. I don't know that. But if you really even if you go to one site, go to the Oral Cancer Foundation website, it is just filled with information. There are other sources as well that you will learn as you go along and become more familiar in your role. But that is one of the places I feel that you can get a lot of good information.
Susan?
I just have to ditto what Maria said about the Oral Cancer Foundation. Just one of the best websites for us as dental professionals and for patients. They have a patient forum for patients and their family that are going through this cancer.
Okay, so let's kind of take it through the steps again. So we have done all of our screening. We maybe have a light that we're using, and then we find something that's suspicious. What's the next step past, hey, by the way, patient, there's something like, what's the verbiage that you say to the patient so you don't scare them, but let them know that it's serious? And then what's the referral process look like?
Well, I would say, if you see something, then start to ask them questions about that. If it's a lesion, have they noticed it? If they have, how long it's been there? And document that lesion. Take an intraoral photo, measure it, thoroughly document in your treatment notes. And then in conjunction with the dentist, hopefully beforehand, the hygienist and dentist have talked about what their oral cancer protocols are. Decide, does this need a referral right now? Or is this something that we want to bring them back in 2 weeks for further follow-up?
And I would say too, there's, just to have in mind who you will refer to, because some lesions and intraoral things you might be referring to the oral surgeon of your practice's choice, but also have an ears, nose, and throat doctor in your back pocket that you have developed some type of relationship with the practice, that there are certain things, if you find a lump in the neck, they have that chronic hoarseness, that may be more of an ears, nose, and throat doctor. And that just helps to cut out the middleman, not that you refer everybody to the oral surgeon, and then from there, the oral surgeon has to refer to the ears, nose, and throat. That has wasted time for that patient. And that is both, I know Susan and I are on a closed Facebook group for head and neck cancer survivors. And I was doing a webinar, a presentation, and I put on there a post, what did your dentist do, or what do you wish your dentist would have done in order to make your journey better? And it was heart-wrenching, absolutely heart-wrenching. And how many people had that kind of same story over and over about how they felt dismissed, how they felt their treatment or their diagnosis was delayed because they weren't taken seriously with their concerns. They were watching and waiting for sometimes years. Sometimes years they were watching and waiting something rather than having it biopsied or checked out further. So those are things that we need to do better on, definitely.
Maria?
I have had the unpleasant experience of detecting 2 oral cancers in my career, and unfortunately they were detected at a late stage. These were both in alcoholics that also smoked, and they succumbed, and it was very, very sad. But what I do now when I find something that is suspicious, I ask a number of questions, and then I will say, I don't like what I'm seeing. I really feel you need to be referred. And then if the doctor is there that day, and I work in California and the doctor is not always there. If the doctor is there, I will call her in and we will confer and we will refer that patient to the appropriate person. If the patient is not there, then I have to do it. And I do. I know who we refer to in our office and I make a note of it. I document it. But I do refer that person because I do feel if it's that serious that they need to go immediately. If it's something that is not that serious, I'll say, how long has it been there? Then I will say, I want to see you in a week, or I want you to call me in a week, look in your mouth to see if it has changed. So every situation is different. But if it is serious enough that I feel that person needs an immediate referral, we just go ahead and do that.
One thing to add to that, what I found is helpful is when I find something that's a variation of normal or an abnormality, say that 3 times, right? Abnormality. I've started relating it to medical. And I tell my patient, just as when you go into your gynecologist or your primary care or to the dermatologist and they're doing different assessments on you and they find something that's maybe different, or maybe your blood pressure's a little bit higher or blood sugar. So just as they are assessing and then referring you to specialists just to have something investigated further, that's what we're doing in dentistry now. And not that we haven't always done it, but just to relate it to their medical situations, that this is perfectly normal and we're going to refer you and have them take a look at it and see what's going on.
And I would just make a plug for teledentistry. Like, what a great way to connect all the dots. Have a patient send me a picture in a week. Is this getting worse? Send me a picture. And if not, I'm going to go send all of these to an oral surgeon, to that ENT. I love having that network that you were talking about.
Yeah, absolutely.
That is one thing with my website, with Side Effect Support. I'm really, really proud that one of the latest things that we had added is a teledentistry service where I partnered with the teledentist. So if somebody maybe doesn't have an office that they consider their dental home, or maybe they're in the middle of treatments, or they have some other issues where they don't have somebody local that they can see, it does allow them to access a dentist 24/7, 365 days a year, just to have an opinion and see where that next step could be.
Andrew, have you ever found cancer or lost a patient?
I personally didn't, but our doctors did a couple times.
That's heart-wrenching. Have you guys personally in your careers?
Yes.
Yeah. I'm going to put Andrew on the spot again.
The answer's no.
Have you had sex conversations with your patients?
Yeah, that's not uncommon.
Yeah.
I mean, that sounded really bad.
Good.
But it is not uncommon in the medical way of what we're doing. Because it was a standard of our health history questionnaire.
Ah, good.
So it wasn't outside the normal. All of our dental assistants and hygienists, we all felt comfortable doing it. So
that's nice to hear. That's nice. There's hope. Anything else that you guys would like, or any advice that you would like to give a new grad or a student, or even somebody who is like just getting back into dental hygiene? Maybe they saw the demand after COVID and they're like, I could go back and do that again. It's been a minute. Any advice for them?
I would just say, and this is from my own experience, you are so busy. You have so much to do. As oral health specialists, we have a lot on our plate. Don't let the busyness of your day get in the way of doing this thorough and complete oral cancer evaluation and educate your patients. The other thing I'm going to say is when we see our colleagues, the other hygienists in our office, do a complete and thorough oral cancer evaluation on them as well. We are at risk also. Just because we're in dentistry doesn't mean that we're not at risk. I know dental hygienists and dentists who have succumbed to oral and oropharyngeal cancer. But that's usually when we get our treatment, right? Is we're squeezed in when there's a cancellation. So just make it a priority, and for your patients and your colleagues.
Maria?
My word of advice would be, do not be bullied by anybody, including your boss. And what I mean by that is, yes, we are busy. We have a lot of things we need to do. And sometimes dentists will actually say, I don't want you doing an oral cancer exam or talking to them about smoking, because if you do that, they might get insulted and not come back. I don't know if this is as common now as it was years ago, but there were actually offices that were doing that. Oral cancer examinations are vital. They have to be part of our protocols. We can save somebody's life. And yes, we're busy. I know, but it doesn't take long to do this. And you do your extra exam, it can take less than 5 minutes. And so the advice is, don't let somebody tell you, you have to speed it up. You can't be doing these exams. I want you to just get in there and do your prophylaxis or your scaling and root planing. Have a protocol and follow the protocol, and make sure oral cancer screening is part of that protocol.
Yeah, those are great tips. And I would just take it a little different direction for advice as far as, let's say you have somebody that has been diagnosed now, is to be proactive in anticipating what they're going to be facing with their treatments as far as side effects in their mouth, and be very proactive with giving them the tools and the information they need to help reduce some of the side effects, some of the long-term damage that can occur, and be empathetic and understanding that some of these effects are lifelong. So you might have somebody that maybe completed treatments 10 years ago. That doesn't mean that everything is back to normal. They are still battling the effects of it, and to deal with that with compassion and make sure that they are not feeling judged because of that. That is one thing that I've heard far too often also, that survivors have a hard time finding an office sometimes where they feel comfortable, that they don't feel judged, and we can definitely make a difference in their life for that.
That's a really good point, Jill. And the other thing I would also encourage is to refer them to a support group. This is a very, very difficult thing. We as dental hygienists need to understand the products that are out there, what works, what doesn't, as far as dry mouth and things that will plague them for the rest of their life. But there's so much emotional baggage, if you will, with something like this. So referring them to a support group such as what you find in the Oral Cancer Foundation website, or I'm sure there are many other in your communities. But that's very helpful to these individuals that will be suffering the repercussions probably for their lifetime.
Well, Susan?
Something Maria said just sparked this, that in the past, sometimes it's been said, don't talk about cancer or don't, talk about that. And I've had it said to me, we don't want to scare our patients, so we don't want to mention oral cancer. I have not met an oral cancer survivor yet who didn't wish that they had known that there was an oral cancer. Many of them have not heard of an oral cancer. And on that same note, if talking about oral cancer is going to scare our patients, then they're petrified when they're walking in our door because they hear about every other cancer on TV and in print ads. And it's to raise awareness so they can be proactive and help themselves. So I think if we get rid of that feeling that we're going to scare them, and we're educating.
That's great. And what a great way to wrap this up, because I feel even more like I need to be doing more, and I'm doing oral cancer screening. So I'm hoping that this inspires everyone who is listening. And I would love to make sure that you guys, or if anybody has questions, that they are definitely able to reach out to you, find your courses. Who would like to go first and tell us where all of that can happen?
I'll go.
Jill?
Well, you can visit my website. It's Side Effect Support. So it's sideeffectsupport.com. There's a variety of services, a lot of free information on there. There are some access to products, the teledentistry, and we do have a lot of, actually both Susan and I have articles out in RDH Magazine this month. Susan has a great one talking about the stigma of HPV. So yeah, a lot of good resources out there for you.
Susan, where can they find you?
I have a website, Oral Cancer Consulting. However, most of my stuff is on social media, on Facebook, on Instagram, on LinkedIn. I do have an oral cancer screening video coming out. We recorded that a couple of weeks ago, and we're editing it. And Michelle, to your point, we're going to cover how you can also be screening for sleep apnea and myofunctional disorders at the same time.
It's so perfect, isn't it? Don't they marry all? They're perfect.
Yes.
To marry all together.
Mm-hmm.
Maria?
So people can reach me. The best way is just to email me. I have a number of Facebook pages on a variety of different topics. I run one for international dental educators, and I run a forum every other year, someplace in the world. So my email address is mariaRDHMS@gmail.com. So I am happy to answer any questions that come along, and happy to hear from students. I occasionally do go to the schools in my local area and speak to students, and I'm happy to do that.
Well, thank you all. All of you are treasures in our industry. You provide so much amazing education. You really empower us to do better so that we can be the best clinicians and save lives. And I just want to say thank you so much. I'm sure Andrew does too, for taking the time this evening and coming on and chatting with or about such a big topic. So thank you.
You're welcome.
Thank you too.
Thank you.
Well, another great week, another great episode. We thank you all so much for listening each week. If you haven't already, hit that subscribe button, whatever podcasting app you're using. Also, just a reminder, our guests are so fantastic that they love when you reach out. They love when you interact with them on social media. And you can interact with us on social media as well at Instagram or Facebook. We're also on LinkedIn. You can find us at A Tale of Two Hygienists. You can also go to our website, ataleoftwohygienists.com, And we would love for you to go there and subscribe for our newsletter. We have lots of stuff on our website. We have a learning center. You can search for any episode. This is an easy place for you to find the links for our CE courses and take the test. There's just so much more there. So head over to atailof2hygienist.com. And if you want, you can also send us an email. I'm Michelle at atailof2hygienist.com. And then there's Andrew, who is Andrew at atailof2hygienist.com. And we just want to say thank you so much. If you love this episode and you're loving the podcast, we would love for you to subscribe and leave us a review. And, 5-star, go ahead and do it. 5-star, just hit that 5-star and then leave us a review. We really appreciate it. We love reading them. It fuels our fire. And we just appreciate you guys so much. I think that's it, Andrew. Anything else?
Nope, that's it. Have a good week, everybody.
Bye, y'all.